On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Robert Shapiro. Dr. Shapiro is board certified in nuclear cardiology, interventional cardiology, and cardiovascular diseases. He received his medical degree from Medical University of South Carolina and then completed internal medicine residency at the University of Virginia and a fellowship in cardiovascular diseases at Washington University Barnes-Jewish Hospital. Prior to joining Boulder Heart last year, he was an interventional cardiologist at UC Health in Longmont and McFarland Clinic in Ames, Iowa. Dr. Shapiro sees patients at Boulder Heart at Erie Medical Center in Erie and in Longmont. Welcome, Dr. Shapiro.
Good evening. My name is Robert Shapiro, and I'm an interventional cardiologist with Boulder Heart. I'm practicing in the hospital here in Boulder and also at our Erie location. It's my pleasure to speak to you tonight about managing your cholesterol. So I wanted to start by talking about why managing cholesterol is important to a cardiologist. And as you see from the cartoon, our major goal is to keep our patients healthy and to keep them alive. And so I'll show you some data as to why I think that managing cholesterol is an important part of the equation. To talk a little bit about the scope of the problem, I want to talk about how prevalent high cholesterol is. So 86 million American adults have high cholesterol. But of those, only 47 million, or 54.5%, take cholesterol medications for it. Additionally, 33% of adults have not had their cholesterol or lipids checked within the last 5 years. When we look at Colorado specifically, we do see that it generally has the lighter colors on the map, which represent lower prevalence of high cholesterol. But when you look at the actual numbers, there's still, between 1 in 5 to 1 in 3 people with high cholesterol in our state as well. So it's an important thing for us to manage. So what is cholesterol? Cholesterol is a waxy substance that's produced in the liver and used throughout the body. We think about dietary sources of cholesterol, but the vast majority of cholesterol is actually produced by the body itself in the liver. It has important functions within the body. We ask, why do we need cholesterol if it's dangerous? But I'll go through some of the important functions that it serves within our body. So primarily, cholesterol is part of the cell membrane. So obviously our body is made up of cells that all throughout the body is cells, and so each cell membrane, so that that portion surrounding the cell needs cholesterol in it to help maintain homeostasis, so meaning the kind of balance of things moving in and out of the cell membrane, as well as to help with the fluidity of the cell membrane. So that's a very important function of cholesterol within the body. Additionally, it helps with vitamin D synthesis. So precursors to vitamin D are made within the liver, and then in the skin, the sun interacts with these precursors and form vitamin D. Obviously, we have dietary sources of vitamin D, but sunlight and these precursors converting into vitamin D are an important part of the vitamin D cycle within the body. And this helps with bone health, absorption of calcium and phosphorus, as well as our immune system function. So this is, again, a vitally important part of the function of cholesterol. Additionally, certain hormones are made from cholesterol, so specifically the sex hormones progesterone, testosterone, and estradiol. So both the male and the female hormones are produced from cholesterol. And also there's steroid hormones, aldosterone, and cortisol, which additionally are made from cholesterol. So again, all of these are vital components of keeping us healthy. Furthermore, bile acids, which are made in the liver, and then transported into the intestinal system through the gallbladder and the bile system is an important function of cholesterol. About 50% of daily cholesterol turnover goes through bile acid synthesis, and these act as an emulsifier for substances within the digestive system and also help with absorption of lipids and fat-soluble vitamins. So this is very important. So one of the questions that people ask is, well, I've heard about good and bad cholesterol, so I'd like to spend some time talking specifically about the differences between the good and bad cholesterol and what we mean when we talk about that. So to start with, I'd like to talk about a lipid panel. So many of you have had a lipid panel checked by your providers, and you see these different numbers on it, and I wanted to kind of go through some of the basics of that. So when we talk about total cholesterol, what we mean is the combination of the HDL or the good cholesterol, the LDL or the bad cholesterol, and then 20% of the triglycerides. And that's what's added together to come up with a total cholesterol score. So then we talk about the low density lipoprotein or LDL, which is what we think of when we're talking about bad cholesterol. So the reason that we talk about this being bad is that it can stick to the walls of arteries and cause cholesterol deposits within the artery. And so over time, as those progress, that can lead to symptoms or even things like heart attack and stroke. So that's why we worry about the LDL or bad cholesterol. Now, on the flip side, there is the high-density lipoprotein, or HDL. And so when people talk about good cholesterol, that's specifically what they're talking about. So the benefit of the HDL is that it actually takes cholesterol from the arterial walls and from the blood and returns it back to the liver to be recycled. And so that can be cardioprotective. So high levels of this really can reduce your risk of having cardiovascular events. However, there is kind of a phenomenon that we see that if the HDL levels are very high, that may be indicative of some sort of other problem. And so then there can be increased rates of cardiovascular events with very high HDL levels. And then furthermore, the triglycerides are a component of lipids that are used for energy. So those get stored within cells and then used when you need, fat energy. But unfortunately, high levels of triglycerides can also be associated with stroke and heart attack. So we keep a close eye on these levels and treat that for certain patients. This is going to be the most sensitive to things like dietary sweets, simple carbohydrates, things like beer. And again, if you have very high levels, in addition to risk of stroke and heart attack, it can also predispose people to things like pancreatitis, which is inflammation of the pancreas. I want to talk briefly about some of the more advanced lipid testing that some of you may have discussed with your providers. So one of these is the lipoprotein A, or Lp(a). So this is very similar to LDL with regards to risk of cardiovascular events. Again, the lipoproteins, LDL, HDL, Lp(a), they're a combination of cholesterol and specific proteins. So we see this structure diagrammed here. And so the issue is that you have, for Lp(a), you have an LDL-like cholesterol particle and this apolipoprotein A protein. And the issue is that specifically this kind of acts on two sides of the pathway that we worry about with regards to cardiovascular events. So on the atherosclerosis side, or formation of cholesterol plaque, the LDL-like particle can deposit within the wall of arteries and then lead to cholesterol deposits within the artery. Additionally, this can affect valves, and so that can lead to deposits within the valve structure and can lead to tightening of the valve and aortic stenosis over time. And then on the other side of the equation, it can inhibit fibrinolysis. So that's where the body breaks up blood clot and helps limit the risk of things like stroke and heart attack. So when you're inhibiting that, then you're at increased risk if you have FACCs and if you have turbulent flow to have things like a heart attack or a stroke. And so this is an important component. And part of the reason that it's important is that it can run in families. So when we look at both men and women, about 20% of the population have high levels, and this, again, can be inherited from your parents. And unlike other forms of cholesterol, this may not be controlled by things like healthy eating and exercise. And so we're starting to really look into this as an advanced thing such that we can reduce people's risk regardless of whether they have well-controlled traditional cholesterol parameters like the HDL and the LDL. Unfortunately, we are still in the kind of research phases of looking at therapies to treat Lp(a). So apheresis is one that is FDA approved, but that is a process similar to dialysis and kidney disease, where you get hooked up to a machine, and then running through the machine, it clears out the Lp(a). So that obviously is not a standard therapy and not something that many people go through. So we're very hopeful that as time goes on in the near future, we'll have directed therapies for this with medications that can be taken either orally or by injection. You may have also heard of ApoB or apolipoprotein B. And so this specifically is a protein structure that is attached to the lipoproteins that cause atherosclerotic plaque. And so this can be directly measured. And what we see is that in some people, despite the fact that perhaps their LDL levels aren't particularly high, they still have cardiovascular events like a heart attack or a stroke. And so, potentially measuring ApoB may be a better way to estimate the risk in certain portions of the population. And so again, we're trying to discriminate where that lies and which people would be best managed by following ApoB. But that may be something that your physician brings up to you as something, especially if you've had cardiovascular events. So why do we worry about high cholesterol? Well, obviously, the main reasons that we worry about it, specifically from my perspective as an interventional cardiologist, is that I want to try to prevent my patients from having atherosclerotic heart disease, which would predispose them to heart attacks. And also, I want to try to prevent my patients from having strokes. I think these are major sources of morbidity and mortality in the U.S., and they remain, major things that we continue to see in a big proportion of the population. And so one of the ways that we can deal with this is to deal with high cholesterol. And so specifically when we talk about the bad cholesterol or the low density lipoprotein, we see that can attach to the inner layer of vessel walls and then get implanted into the media. And so the media is the middle portion of the vessel wall, and there are cells that are within there called macrophages. And so macrophages are kind of the trash cell where it picks up kind of trash. But the issue is that when it picks up a bunch of cholesterol, then it becomes what we call a foam cell. So it's a big cholesterol cell, and then over time these cells can coalesce and deposit cholesterol within the artery wall. And as we move on, they expand and they form kind of the core of this cholesterol plaque within an artery wall. And so we see that over time, with higher cholesterol, that we are forming these cholesterol blockages, whereas the artery previously was much bigger, and now it's kind of starting to impinge upon the lumen of the artery. And over time, as that progresses, that could cause symptoms. And then, as plaques get even bigger, they can become unstable. So if you think about this cholesterol as being fluffy, kind of like whipped cream, and it has this thin cap right along the blood border, if the cap were to break, then that exposes this fluffy cholesterol to the bloodstream. And what can happen then is that blood clot can form at that area because this cholesterol activates the clotting cascade, and that's where we can see acute heart attacks. And so, when we talk about a classic heart attack where someone has, crushing chest pain, they present to the emergency room, they're rushed to the heart catheterization lab to try to open up an artery. This is that process. So this is an abrupt closure of the vessel so that this portion past the blockage is really getting no blood flow, and so this area is dying. And the quicker we can open that up, obviously, the better. But we want to try to prevent these things, and so that's why we talk about the cholesterol so much. Again, cholesterol and lipids are one of the most critical modifiable cardiovascular risk factors. So this was a case control study, which looked at the things that we can modify with regards to cardiovascular risk. And we see that lipids are the highest at 49% of the attributable risk is the lipids. Things that are lower that you would think might be higher, things like smoking is below that. Abdominal obesity, even lower. Hypertension down here at 18%. Exercise down at 12%. Diabetes at 10%. Alcohol at 7%. So as we see, we have, by focusing on cholesterol, we have a lot of opportunity to try to reduce the risk of cardiovascular events. So what can we do? So obviously, our goal as cardiologists and also the primary care physicians, what we want to do is we want to try to prevent cardiovascular disease in the first place. So, and then we also want to aggressively manage those who have already had some sort of cardiovascular disease. So if you've had a stroke or if you've had a heart attack, we want to minimize the risk of you having another one, because if you've already had those things, you're at a much higher risk of having a second event. And so, to start with, we want everyone to follow a heart-healthy lifestyle. So starting at a young age, we really encourage people to be heart-healthy and to think about their cardiovascular risk and try to minimize it. So the benefit of starting early, and so, starting cholesterol screening at an early age and, focusing on diet and exercise, those types of lifestyle modifications, focusing on not smoking at an early age, is that cholesterol deposits start at a very early age. And so there may be minimal cholesterol deposits that are there, and if we can prevent those from getting worse over time, and we start early, then people can have long, healthy lives and not have events. And it's really about creating a strong foundation of health. Additionally, focusing on a heart-healthy lifestyle also may help prevent other risk factors of cardiovascular disease. So things like diabetes, obesity, high blood pressure, all these things are important components of cardiovascular risk. And by trying to be healthy to start with, we may minimize those. I think it's important to take a moment to talk about diet. With regards to diet, dietary studies are tough to do, but there are definitely, big themes that we see as to what is healthy versus what is unhealthy. And so I think that talking a little bit about this and talking a little bit about the data behind it is important here. So the things that we would recommend are the dietary factors that try to encourage lowering cholesterol. So things like fresh fruits and vegetables, nuts, whole grains, lean vegetable or animal protein, fish, especially fatty fish. So these types of things have been shown to lower cholesterol and also to lower the risk of cardiovascular events, which is really the goal here. If we show that cholesterol is a little bit higher, but you're less likely to have a cardiovascular event, I think that's really the goal. So specifically, some of the things that we've seen in small studies that may affect cholesterol specifically, kind of are the things that you would expect for the most part. So things that may raise the cholesterol levels, things like sugars, simple sugars, solid fats, saturated fats, those types of things can affect cholesterol in a negative way. There's a little bit of data that unfiltered coffee, so like French press coffee, may raise cholesterol levels slightly because of some of the lipid components in coffee beans. But filtered coffee would not do that as much, so that's something to consider. It's a mild effect. And then I want to focus on the things at the bottom part of the slide. So the things that really have been shown to reduce cholesterol. So things like whole grains, soluble fibers, things like oats, barley, psyllium, flax seeds, soy, nuts like almonds, walnuts, hazelnuts, the unsaturated oils, so the plant oils that are unsaturated, plant sterols and stanols, as well as things like healthy fats like avocados, and then vegetables like tomatoes, as well as green tea actually can reduce cholesterol a little bit. And then we need to talk about the things that we need to avoid. So there was lots of focus on trans fats in the past, and I think it's important that we continue to talk about the fact that processed foods, fried foods, margarine, those types of things have high trans fats, and those will negatively impact people's cholesterol. Red meats and processed red meats definitely can negatively impact the cholesterol levels. Refined carbohydrates, so think of things like simple sugars, simple breads, white breads, those types of pasta. Those unfortunately do increase cholesterol, and then sugary beverages as well. And then again, people sometimes want to try to find a diet that they can follow to try to reduce cardiovascular events. So there are some certain diets that have had some data to suggest that they reduce cardiovascular events. I bring those up. Things like the Mediterranean diet, again, kind of focusing on those lean fishes, olive oils, fresh fruits and vegetables. The DASH diet, which specifically is for hypertension, but can also reduce cholesterol and cardiovascular events. There's good data on plant-based diets, so vegetarian or vegan diets clearly can improve cholesterol levels. A flexitarian diet, so a diet that's mostly vegetarian, but maybe with a teeny bit of meat here and there, very lean meats or fish here and there. I'll talk a little bit about some data there, as well as portfolio diet. Some people may have heard of that. That focuses on plant proteins, nuts, viscous fiber, phytosterols, and then the monounsaturated fats. Again, all these diets have some data to suggest that they may reduce cardiovascular events. So, if you're looking for some structure to trying to improve diet, kind of looking into those types of things and seeing which ones may be beneficial, then I think that would be these are something to look into. I want to go in just a teeny bit of data to look at how cholesterol is reduced with diet. And so this was a study which looked specifically at the omnivore diet, which is kind of like the general American diet, where you eat a fair amount of meat, protein, but also vegetables and fruits and things like that. And then also the vegan diet, as well as a more flexitarian diet. And so what you see is that clearly the vegan diet has the lowest bad cholesterol number. So the total cholesterol as well as the LDL are much lower. Now these numbers, I should say, are millimoles per liter, not milligrams per deciliter, which is what the normal numbers that you think of. So to get to that number, you would multiply it by about 38 or something. But so what we see is that, the omnivore diet clearly has the highest numbers, and we have statistically significant lower numbers in the vegan diet as well. And then between the two is the flexitarian diet. So here's just a little bit of data to show that these types of diets can modify the cholesterol levels. I will point out, though, that overall, the numbers that we look at, they're not huge numbers, but they are substantial numbers. So I think that the point is that we can make good changes with regards to changing our diet, and then we can actually see the improvement when we look at the cholesterol levels with blood work. So specific things to really consider with regards to dietary modification, reducing saturated fat is an important part. So picking lean meats if you're going to eat meat, removing the skin of things like chicken to reduce fat, broiling instead of pan frying such that fat drains off, increasing the amount of fish, especially fish that are high in omega-3s, so things like salmon and trout, herring, substituting meatless options, kind of focusing on this flexitarian idea, cooking vegetables with minimal oil, without heavy sauces to try to minimize, losing some of that benefit by oversaturating vegetables, reducing fats from dairy sources, and also really increasing fiber and whole grains. I want to switch gears just a little bit and talk about exercise. So really the biggest lifestyle modifications that we can do to try to help with our cardiovascular health are diet and exercise. And obviously, treating other medical conditions, treating blood pressure, those types of things, not smoking. But for the vast majority of people, diet and exercise are important parts of this healthy lifestyle, heart healthy lifestyle. So the guidelines would recommend that people try to get about 150 minutes of exercise per week. And there is some data to show that this can lower LDL as well as triglycerides, but generally at modest levels. I'll show you a little bit of data here. And then it can also raise the good cholesterol, which is a good thing. So we like that it does that. But let me. So seriously, what can we do to improve our health? So with regards to exercise and changes in lipids, I put just a little bit of data from a couple of studies. Again, you notice that they're very small studies. But that being said, looking at this one, so we're talking about changes in the HDL by 4 milligrams per deciliter, which is the normal scale, or decreasing the LDL by 2 milligrams per deciliter. And these are obviously in the millimole per liter, but similar. So we see that these are very modest changes. So we need to focus on other things in addition to exercise. And I'm not trying to say that exercise isn't important, because absolutely I think that exercise is very important for people's cardiovascular health. But what I want to point out is that the idea that you're going to get your cholesterol down to goal with exercise alone, I think is very difficult, if not impossible, for many people. So I think it's diet, it's exercise, and then sometimes it's other things. Specifically in obesity, we see that if you lose 3 to 5% of your body weight, that can actually improve your cholesterol number. So decreasing LDL and increasing HDL. And then stress, cortisol is a steroid hormone, and increased cortisol levels from stress, chronic stress, can actually increase your cholesterol levels. So I think trying to find healthy ways to manage stress, be that yoga, be that exercise, be that other ways of managing stress, therapy, are very important with regards to these types of cholesterol numbers, as well as metabolic syndrome. Unfortunately, despite everyone's good intentions, many people who do a very good job with regards to lifestyle modification, diet, exercise, continue to have high cholesterol. And so for some people, it becomes reasonable to consider medications to help with cholesterol. And so our current guidelines recommend that we start screening adults over 20. And even there are some guidelines for screening children, but I'm obviously not a pediatrician, so I won't get into that today. But I'd like to talk a little bit about the idea of cholesterol medications. So the reason that we care so much in cardiology about cholesterol medications is that we have a vast amount of data with regards to multiple very large studies. So we're talking hundreds of thousands of patients, and we see that there's this linear relationship between the cholesterol level and the rate of cardiovascular events. So when your cholesterol level is low, you have low cardiovascular events, and when your cholesterol level is high, you have high cardiovascular events. And so this is why we focus so strongly on trying to reduce cholesterol in cardiology, both from the perspective of preventing first cardiac events, so primary prevention in healthy people, because the data is the same as in secondary prevention. Now, of course, secondary prevention, when we're talking about that, what we mean is people who have already had cardiovascular disease, so things like stroke and heart attack, and those people have even more benefit from being aggressive. But both camps all have benefit, and so it's important, and that's why we focus on this so much, and why most of you have probably experienced one of your providers talking about cholesterol and the benefits of trying to control it. There are multiple factors that your doctor or other provider would consider with regards to what the most appropriate treatment is. So things like age, your risk factors, your history of cardiovascular events, and then shared decision making. So talking to you about your specific circumstances and trying to make an appropriate decision with regards to whether some sort of therapy. And this is a very busy slide. I wasn't really going to go into it much, but basically this is a slide kind of showing some of the different areas where cholesterol medications may impact cholesterol. And so, some of them work within the liver to block production. Some of them work with regards to moving cholesterol out of the bloodstream into the cells in the liver. Some of them work in the digestive system to minimize the risk of bringing in cholesterol. And we'll talk briefly about all of these. So, the statin medications, many of you have heard about. These are the most commonly prescribed cholesterol medication. And the way that they work is they work by blocking a pathway where cholesterol is made within the liver. So in the liver cells, when the liver is trying to produce cholesterol, this certain point in the pathway gets blocked, so you don't produce as much cholesterol, very simply. But the other way that it works is that it helps by creating efflux of the bad cholesterol, low density lipoprotein, being returned to the liver to be digested. So that helps reduce your cholesterol. And then finally, it works actually within the arteries and within cholesterol deposits in the arterial wall. So one way that works is that it reduces inflammation. And then it also changes the composition such that cholesterol plaques are stabilized. And so the benefits of both of these is that when we talked earlier about the cholesterol deposits breaking open and forming blood clot acutely, then if we stabilize these plaques, then they're less likely to do that. So then patients are much less likely to have things like stroke and heart attack. So I think this is a very important thing to consider with regards to these medications, because regardless of whether the cholesterol gets reduced, you also have this additional effect of inflammation going down. But the vast majority of people on these medications, the cholesterol gets drastically reduced, and so that's a main reason that we see such benefit from these medications. Now, I think it's important to talk a little bit about side effects when we talk about statin medications. So I'm going to go into that just briefly. So many people are familiar with the idea that statins can have side effects. And when we look at statin side effects or adverse events from studies over time, there's a large component of what we call subjective events. So meaning people have muscle pain, but they don't have evidence of breakdown of the muscle or damage to the muscle, or they have other symptoms that they feel subjectively. This is not that these are not tolerated well. But when we look at the actual number of objective adverse events, it's very low based on the population of people who are on these medications. Interestingly, in this study, it looked at the U.S. versus non-U.S. populations, and actually the subjective rates were much higher in the U.S. versus the non-U.S. For whatever reason. I won't postulate as to why, but I think it's an interesting thing to point out because physiologically we would expect that those would be similar. An additional study that I wanted to bring up was a study with regards to specifically patients who had experienced side effects from statins. So they took people who had already experienced side effects, and they were given a randomization where they were either given a moderate intensity dose of a statin, they were given placebo, or they were given no treatment. And so at different points of time, they were supposed to do one of these three things. And within an individual, they each did these types of things at different points in time. They didn't know specifically what they were doing. And when we looked at each individual here, we see that there's really very, very poor correlation between the use of the statin and symptoms. So people had symptoms with placebo, people had major symptoms when they were on no treatment, and clearly there are some people who don't tolerate these medications, but frequently people were able to tolerate these medications, and they didn't even realize that the symptoms they were having had nothing to do with the medication because they were having them when they weren't on the medication. So, I just bring this up because it's a common thing that people are concerned about, and we want to do what's safe for people, and really these are very safe and well tolerated medications. And so obviously some people will have bad effects from any medication, and we want to keep an eye out for that. But many patients can tolerate it, and then they can live a long and healthy life based on taking medications if needed. I'd like to talk briefly about some of the non-statin therapies that you may have heard of. So one of these is ezetimibe or Zetia, and that actually blocks the absorption of cholesterol in the digestive system. So it decreases it about 54%. And so that results in about a 20% reduction in bad cholesterol. But frequently this was tested in combination with the statin therapy. So when we look at the guidelines, most frequently this is used in patients who need more aggressive cholesterol management despite maximally tolerated statin therapy. And so this may be something that your physicians would bring up. Sometimes if people are intolerant to statins, they just can't take that medication, then they may be put on this type of medication. Finally, one of the newer classes of medications is the PCSK9 inhibitor that some of you may be on or may have family members that are on or friends. And this is a monoclonal antibody which binds to a specific protein which is called PCSK9. I won't go into the name because it's quite a mouthful. But what this does specifically is that it blocks the PCSK9 from binding to the LDL receptor. And when that normally binds to the receptor, when the receptor binds LDL and then gets internalized into the cell, then those all get broken down. So that reduces your number of LDL receptors. So there's less receptors that are available to catch more LDL. And so if we block this from binding, then what we see is that the LDL gets internalized into the cell. The LDL particle comes off of the receptor, and then the receptor gets recycled back to the outside of the cell to pick up more LDL. And so this can result in a drastic reduction in LDL. So these are, unfortunately, these are injection medications. Most often they're given every 2 weeks. So that's one of the downsides. And one of the downsides, obviously, is the cost, because newer medications are expensive in our country. But we do have many patients who have high cholesterol, who need these types of therapies, and who have excellent results with regards to lowering their cholesterol and lowering their risk of cardiovascular disease with this type of therapy. So this may be something that, especially in patients who are very high risk, who have had, heart attacks or strokes, and then, if they can't take statins or things like that, this may be something that your providers talk to you about. And I think it's an excellent strategy for managing cholesterol. I'd like to talk just briefly, and I know this slide is a lot, but I want to talk about what the guidelines that we follow in cardiology and what your providers are thinking about when they're trying to make decisions with regards to the individual patients. So I wanted to start with secondary prevention. So I'll remind you that means someone who's had a heart attack or had a stroke. And generally speaking, the takeaway from this slide, I think, is that generally everyone who's had a heart attack should be on a high-intensity statin if they can tolerate it, because we have just vast amounts of data to say that is going to lower their risk of having another heart attack or another stroke. So, with regards to older patients, I think the challenge with regards to our over 75 patients is that frequently early on, a lot of studies excluded patients over 75. And so the data was less available with regards to those patients. In general, those patients still should be on at least a moderate intensity statin or continued on a high intensity statin if they're doing well on it. And I think importantly, those patients have a lot to benefit from these types of therapies because they are at high risk. And then the other thing, again, is that we target goals. So, bad cholesterol of less than 70 is frequently the goal. And if you don't reach that goal, we may consider adding Zetia if you're kind of not at very high risk. If you're at very high risk, we would definitely consider Zetia. And then if you continue to have high bad cholesterol over 70, we would consider adding the PCSK9 inhibitors. So that's kind of the stepwise approach to managing our high-risk patients who have already had events. And then finally, I'd like to go a little bit into the primary prevention. So obviously, we want to prevent people from having heart attacks. So this is even a bigger population of people. So that's why this slide is a lot to take in. But generally speaking, I think the things to focus on here is that every adult age 20 to 75 should have screening cholesterol levels. In people who are young, 20 to 39, if they have a really strong family history of cardiovascular disease, or if their bad cholesterol is greater than 160, they may want to talk to their doctor about cholesterol medications. In patients who have bad cholesterol greater than 190, those patients should be on a high-intensity statin therapy, regardless of what their risk is, because we reduce events by doing that. People who are diabetic and age 40 to 75, they should be on at least moderate, if not high-intensity statin therapy. And then the majority of people are these 40 to 75 people who we want to quantify their risk. And so we use a 10-year risk score, which your provider can plug data specific to you in, age, whether you have high blood pressure, whether you're on medications, whether you smoked, and then see where your risk is. If your risk is low, less than 5%, we would recommend lifestyle modification. If you're kind of in a borderline risk, talk about whether you have certain things that would enhance your risk, which would push us towards medical therapy. If you're in the intermediate risk class, again, talking about risk discussion, but by considering at least a moderate intensity statin to reduce the bad cholesterol by 30 to 40%. And then finally, if you're in a high risk, initiating cholesterol medications with statins to reduce the bad cholesterol by 50%. And then finally, with regards to calcium scoring, because I know we talk about it all the time, So really the guidelines would recommend calcium scoring to try to help make a determination in intermediate risk people as to whether they want to be on cholesterol medication. So if you're in an intermediate risk class and you have zero calcium, maybe you're at slightly lower risk and you may not want to start medications. If you're in an intermediate risk and you have calcium in your arteries, then that would suggest that you have some plaque there. And then again, these are discussions to be had with your specific provider, but those patients probably benefit from being on cholesterol medications. So just to wrap up, management of cholesterol is generally a multi-pronged approach. So it includes diet, exercise, lifestyle modification, and really discussion with your providers to help improve your cholesterol. And things like routine exercise are very important and can help lower cholesterol to some extent based on studies. But unfortunately, many people still fail to reach their goals despite their best intentions with these types of lifestyle changes. And so I would remind you that cholesterol medications in general are very safe and well tolerated, and they have a lot of data to suggest that they reduce both cholesterol numbers as well as the risk of cardiovascular events. And so with that, I would like to take any questions.
Thank you so much, Dr. Shapiro. That was very detailed and informative. And we want to let our audience know that now is the time to ask questions. We have already received some questions, and we'll start asking those in no particular order. And we'll also get to as many as we can tonight. This person, they said, unfortunately, they cannot swallow pills, and high cholesterol runs in the family. If they need help, are there any liquids, powders, or chewables that can help?
That's a good question. I would have to look. I'm not certain whether some of the cholesterol medications are actually crushable, such that they could be made into a powder. So I don't know the answer to that off the top of my head. Clearly, I think that's a great discussion to have with their provider, because I think if you're unable to take oral medications, that may rule out some of these medications if they're not available in those types of forms. And then the injection medications are excellent medications, and obviously that would take that totally out of the equation.
What do you suggest in order to bring down triglycerides specifically?
So, I think that with regards to triglycerides, that's a very good question. The triglycerides are going to be the most sensitive to diet. So, and the things in the diet that really raise the triglycerides are those simple sugars, those simple carbohydrates. So when we think of bread, sweets, pastries, and beer, those types of things, those are really going to raise the triglycerides the most. So trying to avoid those to start with. The other thing, it kind of depends on whether someone has diabetes as well. So really aggressive diabetic control, so controlling the blood sugar levels to an aggressive level, can also help reduce the triglycerides. And so those would be the things that we would generally start with. Again, like we saw with some of the data, the exercise also helps with reducing the triglycerides. So I think that's an important part of the equation. I think that those would be the things that we would recommend starting with, and then keeping a close eye on it with your provider. Sometimes we talk about other therapies to help with triglycerides. So I didn't talk about the specific triglyceride medications, but there are medications which can actually reduce triglycerides. And some people take fish oil as well to reduce triglycerides. So that would be something to discuss with their provider.
Is there any science suggesting that statins may reduce or eliminate already existing plaque?
That's a great question. So the idea of regression is an important topic. So obviously, if we were to design the penultimate cholesterol medication, what we would want to do is pull all the plaque out of the arteries and never allow any to redeposit there. I think that the likelihood of regression with the statin medications is low. It's not zero, but we don't routinely promise that with regards to the statin medications. Our goal there is to limit progression. So, for instance, if you had a mild blockage in an artery and we kept it mild for the rest of your life and it was stabilized and never broke open, then you could live the rest of your life and never have any problems from it. And that, I think, is the biggest goal with regards to the statin medications. I think the data is more compelling with regards to regression with the newer medications. So the injection medications, the PCSK9 inhibitors, I think that some people can have regression with regards to that therapy. The other avenue that's being looked at, but is not in prime time, there's an idea of, for people who are at very high risk, so for instance, people who've had a heart attack, they're looking at kind of analogs of HDL as an infusion in the setting of having had a heart attack or a stroke, and looking at trying to cause acute regression, because frequently those people, they may have one area that was the acute problem, but they have other areas of cholesterol within the artery because this is a systemic process. And so I think that's that's somewhere where we're really looking at what we can do differently. And I think that the new medications are probably going to be the future with regards to talking about regression.
Nice to clean up everything, right? This person has heard of a test to determine the size of cholesterol particles. Does the particle size of the cholesterol matter?
The short answer is yes. The cholesterol particle size does matter. It's not routinely recommended within the guidelines currently that we measure particle size. So I think that's a good discussion to have with your specific provider and discuss an individual's risk and what benefit we think we're going to gain from measuring the particle size specific assays versus measuring the standard lipid profile with maybe some adjunct of some of the newer LP(a) or ApoB and those types of things. So I think it's I would recommend that's a great discussion to have with your provider to see if you think that, like, in your specific case, that would be beneficial.
Do you know if there is any scientific evidence that elevated thyroid levels, hypothyroid, would explain high cholesterol if there are no other indicators to explain why a person's cholesterol is high?
Clearly, thyroid disease can affect the cholesterol level. So the short answer is it could be. I think that it's a challenging question. And like we talked about, high cholesterol is very common. So I think that, and thyroid disease is very common. So I think it's challenging to say specifically that it's a causative effect. But I mean, clearly, I think in an individual case, that could be a good discussion, especially if the thyroid disease is corrected and the cholesterol corrects. I think that would be kind of that type of study within an individual that would say that maybe in their case that is mostly the explanation.
Okay. Do you recommend COQ10 for persons who have taken statins for many years? And if so, is there any particular brand that you recommend?
That's an excellent question. Clearly, we have patients who feel like taking CoQ10 helps them with regards to maybe muscle aches or other side effects, or not having those. I don't dissuade patients from using that if that's helpful. Unfortunately, I don't think that the scientific data was particularly helpful with regards to saying that it definitively helps with those types of things. So the studies that I'm aware of, again, I don't think it caused any harm, but I don't think they proved the benefits. So I kind of leave it, I leave it up to my patients. If they feel that it helps them, I encourage that because I don't think they're doing any harm to themselves. But I don't, as a routine, make that recommendation because, again, I just don't think that we have the scientific data to say that you need to take that. So, yeah, and with regards to a brand, I don't have a specific recommendation.
Once a person starts cholesterol medication, do they have to stay on it for the rest of their life?
I think that's a complicated question, and so obviously it depends on the individual. But generally speaking, individuals have a reason to go on a cholesterol medication, and unless that's something that's modifiable, so unless there's something that we can do, again, like to the point of if it were thyroid disease that specifically caused it, and then the cholesterol went exactly to normal after it was fixed, most people, the reason is that they have certain risk factors, or their cholesterol is very high, or they have evidence of buildup of some plaque. And so for the vast majority of patients, the recommendation is to remain on it because by doing so, those people live longer and they're less likely to have things like strokes and heart attacks, and that's the goal. Now, if you have problems with it, that's a different story. So it's not that you always have to be on it. It's that for most people, they would benefit from being on it. And so we would recommend continuing with that therapy, again, unless there's some contraindication to continuing it.
How much of a role do genetics play with high cholesterol?
I think that's an excellent question. And we see definitively that for certain people, genetics plays a substantial role in their cholesterol and having high cholesterol. I didn't go into the specifics of like the inherited high cholesterol syndromes, but I think that we very clearly see that higher cholesterol runs in families, and when we talk about the risk factors, we clearly see that certain families have high cholesterol, and because of that, they really need aggressive therapy. And this is the one thing we talk about all the modifiable things like diet, exercise, not smoking, taking your medications, but the thing that you can't control is your parents. And so I think that's where, with regards to cholesterol, I do encourage my patients to understand that this is not all them, and that there are things that you can do to make things better, but you may not improve it 100% because, again, it's just your genetics.
We just have time for a couple more questions here. With diet and exercise changes, how many months would it take to notice a difference if having a lipid panel done, again, to check progress on reducing your LDL levels?
That's a good question. The studies that I showed, they were fairly. It was actually fairly quick. I think it was within a few months. They were showing some decreases in the cholesterol levels. Generally speaking, when I see my patients, I usually recommend giving things like 3 to 6 month trial to kind of see where things go. But obviously that would be an individual question, depending on people's risk factors to, have that discussion with your provider. But that's usually my recommendation, is to kind of give it 3 or 6 months to kind of let things get to the new steady state and then recheck it to see how things are going.
Okay. A couple things about specific foods. Does coconut oil make cholesterol high?
So the short answer, and I haven't researched too much on the specifics of coconut oil, so I don't want to give incorrect information. I think that with regards to oils, obviously these are fats, and so I think that using them in moderation is important. I don't know the specifics of coconut oil, and so I don't want to give you the wrong information.
Can you compare eating fatty fish versus taking omega-3 supplements?
I think, that's an excellent question. So I think that people who need fish oil supplements for high triglycerides, I think that's an important part of therapy that you would discuss with your providers. Generally speaking, we recommend getting the nutrients from whole foods, so as opposed to supplementing as best you can. And so I think as dietary guidelines go, we would recommend that there's probably effects that we don't even understand with regards to the protein, the lean protein, and the fats in fish. And so I think overall, we would prefer people have a well-rounded diet that includes these things as opposed to trying to just get them with supplements.
And then can apple cider vinegar or red yeast rice help with reduce cholesterol?
I'm not aware of the data on apple cider vinegar, so I don't know the answer to that. With regards to red yeast rice, specifically, that is a weak statin. So that when we talk about statin medications, that is similar to lovastatin. And so it does, yes, it does affect cholesterol in the same way that a statin medication does.
We have come to the end of our time.